So we'll just discuss. I don't know how many pediatricians are there, but I know that many adult intensivists are also doing pediatric ECMO. And of course, ECMO started in pediatrics by Professor Bob Bartlett. So ECMO in PARDS, overrated or underutilized. I really like this heading, and another paper which said to ventilate, oscillate, or cannulate, because very often in pediatrics, our adult counterparts have surpassed us in India, and I think in the world, they do much more ECMO for their patients. In pediatric, as pediatric intensivists, there's a lot of hesitancy. Could we cause more harm? It's very expensive. Should we wait? And in this dilly-dallying, oscillating mind, we actually delay precious time and a potentially life-saving modality. We are depriving our patients. So we know the outcome neonatal is very good. And this, you would have seen the slide quite often in all the talks. And survival to discharge is 55%. Even in ECPR pediatrics, its survival to discharge is 41%, which is fantastic because it would have been a 0% survival to discharge, and you've changed it to 41% with the help of ECMO. So two things that one has to ask when we are, before putting a patient on ECMO, be it adult or pediatrics, what is the path ahead with ECMO? Is there a chance for good survival, either transplant or even without transplant? Is ECMO more likely to help or hurt? If you can answer this and get the answers, then you know which path you should be taking. Remember, these are the sickest of sick patients, and you're actually converting 80% mortality to survival, and should be definitely considered when risk of mortality is approaching 50% and introduced when it's nearly 80%. And the key is timing. If you delay ECMO and let multi-organ dysfunction set in, then your outcomes will be poor, and you cannot blame the technology. It is because the timing was late. So how late is late? So in neonates, you can wait up to 14 days. So when we talk about days before ECMO, it is the days on ventilator, on high ventilator settings. If they have just been on HFNC, a little bit of BiPAP, then it doesn't really matter. So we are talking about high ventilatory settings that could have injured the lungs. And if that's been more than 14 days in neonates, or about 10 days in pediatrics, and I think 7 days in adults. So as you increase the duration of, ventilatory support on high ventilatory settings before you initiate ECMO, then the chances of your survival also diminishes. So ideal would be, as Bob Bartlett would say, about 48 to 72 hours, you should make a decision of putting the patient on ECMO. The more air that you blow into the lungs with high ventilatory pressures, remember FiO2 is very toxic, and 100% FiO2 is actually increasing your mortality. So you can see this is the PALIC guidelines for PARDS. Like you have your Berlin's criteria, etc. This is the criteria for pediatrics, where we also look at OI, and there's something called OSI. Remember, for OI, you need your PaO2, which means you need your blood gas, you need an arterial line. We can't keep sampling, or if there's delay in getting an art line in small kids, then we use the saturation itself to collect your OSI. And this is, so severe ARDS is anything where OSI is more than 12. Now, what are the recommendations in pediatrics? So when do you initiate ECMO? If there's failing response to treatment, when lung protective strategies fail and it's reversible cause, there is no strict criteria. So that is the most important recommendation. So you have to serially evaluate, and if there's worsening, initiate it early. What type of ECMO? For ARDS, it's veno-venous ECMO. Important, avoid hyperoxia because that can cause free radical injury, and slow changes in PCO2. If you drop your PCO2 precipitously, you'll have neurological events. And general lung protective strategy. So I was talking about the OSI. So what is OSI? It replaces your PaO2 with SaO2. So what you give by what you get. That is the way you remember this formula. So what you give is your mean airway pressure times your FiO2, and what you get is your SpO2. So you just have to replace this is your saturations. So severe ARDS is more than 12. So when should you consider ECMO? If your OI is about 25%, many centers in the West have initiated ECMO with an OI of 25. They do not wait for an OI of 40 because by then you've already caused a lot of ventilator-induced lung injury. And of course, if there is an OI of 25 with high lactate, your RV is failing, you're on vasoactive support, then it's better to put on ECMO. Then your AO-DO2 gradient, PF ratio. If PF ratio is less than 150 with unsafe high vent settings, it's better to initiate. You don't wait for a PF to drop 100. In viral pneumonia, what we have noticed is many times the OI doesn't go up so high because they don't tolerate high PEEP. They're not recruitable. But the PF ratios could be very low. It's only about 80, but your OI would still be about 20 or so. So it is not just one parameter. It is a combination of parameters that you would see. If they're not responding to conventional, if they're on very high FiO2 settings, then that itself is bad. You don't have to just go by one criteria like a OI or OSI. And rate of deterioration and how quickly ECMO can be initiated. You don't want to initiate ECMO in the middle of the night. You would initiate it a little more on controlled settings. Now, hypercarbic respiratory failure. So ECMO has been initiated by many of my colleagues in India for bronchiolitis, for asthma. So this is something called where the saturations is not a problem, but it's your PCO2 and your RV fails. So this is something called a ventilation index, where you have your PCO2 times PIP times respiratory rate by 1,000. And if it's more than 40 for 4 to 6 hours. So when we say 4 to 6 hours, you have to serially evaluate. And if you have two abnormalities in your checklist in the 4 to 6 hours, then you will have to be initiating them on ECMO. Now for air leak, early ECMO gives total lung rest. It allows reduction of airway pressures. You can manage only with CPAP. So this is a patient who we just put on TPs, sedated. We just disconnected from the ventilator because the patient had air leak and waited till all the bubbling stopped. And then again, slowly started CPAP and then a little bit of the pressure support and gradually increase the ventilator settings. Now, due to risk of bleeding, hemodynamic compromise should be the only indication for chest tube for pneumothorax. So only if there's tension pneumothorax would you be putting a ICD on ECMO with heparinization. So you'll have to ideally stop the heparin, wait for some time, don't start it immediately because you will convert a tension pneumothorax to a hemothorax. Other indications for ECMO in pediatrics for hypoxemia is, of course, your airway surgeries and post-operatively to heal the surgical side, during lung transplantation, any medial cell mass biopsy, and of course, bronchoalveolar lavage. A lot of procedures are done on ECMO in pediatrics. And as you can see, is for foreign body aspiration, hydrocarbon, kerosene aspiration ingestion is very common in India, and hydrocarbon pneumonia. And this could be, ECMO could be life-saving in these patients because kerosene lungs, they pop off. So if you use high ventilator settings, they will just keep blowing pneumo. So ECMO will really give lung rest in these patients. And for burns with respiratory failure, tracheobronchial trauma. So if you could look at this, the difficult airway algorithm, you have ECMO, so which is very much there in the algorithm. What about trauma? Up until now, it was considered an absolute no-no that if you have some brain bleed, you're not to be on ECMO because you have to systemically anticoagulate. But now, you can perform ECMO without anticoagulation. So even ARDS, post-traumatic ARDS, with a bit of head trauma, little bleed is not at all a contraindications, even intra-abdominal injuries. Immune compromised children, if they can be candidates for ECMO, if they have respiratory failure or shock, provided they have a chance for a good survival. And the time limit, of course, there are strict guidelines now for ECMO and immune compromise. So you wait for about 2 weeks on ECMO, and if this patient is not improving, then you would not keep continuing. Newborns, this is where the success story started, Esperanza. So meconium aspiration syndrome, even we have done for one patient who actually celebrated the first birthday a few months ago, and a very, very good survival rate. Of course, for congenital diaphragmatic hernia, because of pulmonary hyperplasia, it's not Great. So as you can see, the contraindications for ECMO in pediatrics is really shrinking. Only if there is no chance or no purpose or no ability you would not be doing ECMO. Otherwise, the traditional contraindications, transplant, trauma no longer exist. And ECMO can be performed without anticoagulation for short periods till bleeding is stabilized. Now, veno-venous or veno-arterial. Dr. Gupta was telling about VA and VV, central cannulation, etc., in septic shock. If you have a patient with ARDS who is in shock, and multiple inotropes, the cause of shock is RV dysfunction, cor pulmonale. And so still go to VV ECMO because it is a lot more easier to manage, less complications. And many times what we have seen is the minute your CO2 comes down, your pH corrects, the RV recovers, and we are now shifting from inotropes to antihypertensives like SNP because there is sudden hypertension and VV ECMO for ARDS. Dual lumen VV cannula, very good, but it's not available in India. Only few centers have gotten some imported samples and they have performed. So we have no experience with dual lumen. It's technically a little more challenging to introduce it. So VV ECMO is the choice for refractory hypoxemia, ARDS, even with shock. Now, when would you do VA ECMO for ARDS and hypoxemia? So if you have a child, neonate, or any child less than 15 kilos, because the femoral vessels are not very well developed, and you would not have good flows if you cannulate them femorally. In this situation, just for getting good flows, you would opt for VA ECMO. This is your peripheral neck cannulation, VA ECMO, just to get good flows. So the indication would still be hypoxemia, ARDS, but to get flows, you would opt for this VA ECMO cannulation. A VV double lumen cannulation has become modality of choice for pediatric respiratory failure world over. It's a lot easier. You just need one lumen and then you can put the cannula, and shorter duration of ECMO runs in VV. Now, this is very, very important for fellows. Please, in pediatric, brain is very vulnerable to the CO2 changes. There is more neurological complications and much more than in adults, both bleed as well as infarct. So this was a patient's PCO2 about 115 pre-ECMO initiation. And if you drop it very rapidly to below 100, which it will, when you increase the sweep gas, because CO2 is very diffusible. The minute you increase the sweep gas, even in the conventional rate, it will rapidly drop the CO2. So the higher the CO2, the lower the drop should be. So because the CO2 has been high for a long time, and the brain will not tolerate this drop. So the studies in pediatric have state that for the first 3 hours, your CO2 drop should not be more than 25 millimeters of mercury. And the delta CO2 decrease should not be more than 30% within the first 24 hours to avoid neurological complications, because this is the time you are actually anticoagulating. You're from hypotension, your blood pressure has gone to hypertension, and the CO2 change also could contribute to neurological problems. Now, these are some prognostic scores that we use not to initiate ECMO, but to actually counsel the family. These are more objective criteria to say what are the risks, what are the chances of the child coming out. They are not for patient selection for ECMO. So there are adult scores, there are neonatal scores, and these are available in the ELSO website. So PPREP, P-Rescuers, and I think there are some newer ones as well. How do we cannulate in pediatrics? Smaller kids, we open cut down. So it's called semi-Seldinger, where we do open cut down, see the vessel, and then put the guide wire in. And then, of course, use the semi-Seldinger technique. Use the Seldinger technique. Now, very, very important, the minute you get to a call that a patient needs an ECMO, please tell the weight, age, and blood group. So blood group, your blood bank will immediately stock all the blood products that are needed for priming, because less than 20 kilos, you want to do blood priming. You don't want to prime just with albumin because it will cause more hemodilution. But the cannula size, length, very, very important. So this is your VV ECMO. One is your internal jugular, and then you have your femoral. This cannula has to extend right up to your IVC. If it is stopping short only at the femoral, then you will not have good flows. So, and this is what happened. Look at this patient's face. He became very puffy because we were not getting good flows and we kept giving fluid and fluid for all the chattering. The chattering is not due to hypovolemia. The chattering was because the cannulae were just in the femoral and the femoral vessels were collapsing. Femoral vein was collapsing as the pump was pulling the blood. So we had to put one more femoral cannula as drainage. And then that goes into the ECMO, and then the oxygenated blood was going into the internal jugular. So 2 femoral venous drainage. So if you don't get it right in the first place, you will not have good flows. And so put the largest and the longest for a good drain. You'll never be able to wean the patient off ECMO. So you have to get that first step right. This was a patient, ARDS, femoral vessels are small, and this a VA ECMO, neck VA cannulation. Now, how do we think, do the ultra lung protective? So it's not a lung protective, it's ultra lung protective. We are giving very, very low tidal volumes. We are not even bothered about the tidal volumes. Initially, it could be even 2 or 3. We don't even target the tidal volumes. And as the lung improves, you'll see the tidal volumes improving for the same pressures that have been set. So it's the 10-10-10 ratio. So your plateau pressure 10, driving pressure 10, and PEEP of 10, respiratory rate, low respiratory rate, because a higher respiratory rate also causes injury. And FiO2 low. Remember, every 0.1 increase in ventilator FiO2 is associated with the mortality. So 100% oxygen, etc., is increasing your mortality by 38%, 0.1 increase in FiO2. So that's very, very significant. And fluid overload, we try to get them negative very fast, because then only you'll be able to wean these patients off ECMO. First 48 hours, small children, we do paralyze because you don't want them pulling out the cannulae. You want to get the sedation right first. So initially, we may tend to paralyze them 24 hours because we don't want to take any chance. And then once we have things in control, then we stop the paralysis, get them negative fluid balance, lighten the sedation after 7 days, try to put them on spontaneous mode, provided they don't have air hunger. Tracheostomy much later, after about 2 weeks, we will know which trajectory the patient. So even 23 weeks is fine in pediatrics. We are not so aggressive with tracheostomy because they can bleed a lot on ECMO. Hypoxemia, of course, you look at the ECMO pump flows, recirculation, and then patient-related factors, your residual lung function and demand, reduce your demand. Now, PEEP. So pressures we limit, but if your patient is bloated like this, with a lot of pleural fluid, abdominal fluid, etc., you may need to give a little more than 10. You may need to give about 12 or so as you're slowly weaning to prevent atelectasis. Otherwise, all your basal lobes, etc., would be collapsed just to open them. So because your true transpulmonary pressures are much lower. So when you have positive pressures, your pleural pressures are positive because of all this around, then your true transpulmonary pressures that you give in by the pressures outside, pressure in minus out, that will be much lesser. So you could go up on your set PEEP so that your true PEEP that is delivered will be much higher. Now, spontaneous mode, it's good to get the patient on spontaneous mode after a few days. But if there is a lot of air hunger and bad lungs, ARDS lungs, there is a lot of increased respiratory drive. And if you can see that patient is taking deep breaths, then your transpulmonary pressures are much higher than what you are delivered, set in the ventilator. And that can cause stress and strain. So we would prefer to go back, sedate the patient and not put on spontaneous mode. Proning on ECMO, it has been done in pediatrics. It's easier and you can see the response. So the same benefit that happens in non-ECMO patients, and it has been done in, it also helps hasten weaning of ECMO. But you'll have to be very careful. Ensure your cardiac surgeon, your perfusionists are there to hold the cannula. You don't want any catastrophe then. Tracheostomy, in pediatrics, we wait for at least about 3 weeks. Late tracheostomy is anything more than 21 days. A higher mortality in the no tracheostomy group. So don't continue without tracheostomy for a very, very long time. Why? It helps come off sedation. So when you have a tracheostomy, you can reduce, there's no biting, chomping on the ET tube, you can reduce your sedation, and it's a lot more easier to manage the patient with a tracheostomy. So timing is important. You have to stop the heparin. There could be some local bleed. You can put local or nebulized tranexamic acid to reduce the post-tracheostomy bleed. It helps even secretion management. Now, this is a very nice paper by Martin Neighbor in 2023, quite recent, mechanical ventilation during pediatric ECMO, and which very clearly, tells the ventilatory mode, pressure control. Why don't you choose volume? Because you won't know what volume to set, and you don't want to set any target volume. You want to give lung rest. Low respiratory rate to reduce the power, limit the lung stress. How do you reduce the stress? By reducing your plateau pressure less than 24, driving pressure less than 15, and lung strain you reduce by low tidal volumes and keep a little higher PEEP, 10 minimum. The role for prone positioning is unclear. Neuromuscular blockade, not routinely. Corticosteroids, definitely no if there is infection. Inhaled nitric oxide doesn't really help. Spontaneous breathing, as I mentioned, balance risk and benefits, and you have to monitor the respiratory drive. So this was the patient, as I said, T-piece on ECMO. We haven't ventured to awake ECMO. Awake ECMO is basically extubating the patient on ECMO. Now, bronchoscopy, we do it routinely, but you have to be ensure that your bronchoscope is not infected. So we have, sometimes you get, we got these disposable bronchoscopes. They are not cheap, but they are better than, using a shared bronchoscope, and we keep it only for the ECMO patient. It was about 40K or so, but we kept re-sterilizing and used only for the ECMO patients. It helped, look at the clot in the ET tube. So we would never be able to wean if this clot is not dislodged. So early bronchoscopy had more ECMO-free days, more ventilator. These are studies in pediatrics. Awake and sick ARDS patients, you would never want to keep them awake or extubate because they'll have so much air hunger, they'll have asynchrony, you will not be able to extubate them. So when we talk about awake ECMO in children, it is for a very stable patient, much later down the line, almost recovering, not in the acute ARDS phase. It must be, you have to weigh it against the risk of cannulae kinking, dislodgement. So we are a little reluctant to pull off the ET tube and just keep some low sedation in background. Imaging, very, very important because the cannulae can migrate. You must short neck in pediatrics, and the cannulae, even a little bit of neck movements and your cannulae can come off. So please do chest x-rays daily, smaller kids, if not alternate days, and to look for the cannulae position, apart from looking at the lungs, etc. Chest x-ray, ultrasound lungs, and cranium in small infants to look for any bleed. CT imaging, if there's no response or if there's sudden worsening, you may have to take the child for CT and just look, or before any procedure like VATS. So you need a CT imaging, and that can be done. MRI, these are not MRI compatible, so you can only do CT, not MRI. Echocardiography in neonates and pediatrics and ECMO, invaluable, especially before cannulation, to know whether you have to put a VA or a VV ECMO. If there is LV dysfunction, you would want to do a VA, but if it's just RV dysfunction, ARDS, then of course a VV is good enough. And of course for troubleshooting, weaning. Nursing team, very important for all your position change, your back care. We put air bed before the patient comes, and you have to educate them, monitor for infection. And if they are also, they understand what is expected and what to monitor, outcomes will be good. 10-year survival, we have had follow-up of 10 years of our patients, and they are doing really well. One of the first ECMO patient has now actually has studied to be a perfusionist, and she's getting trained in a major center as an ECMO perfusionist. Lung has a potential to heal. VA ECMO has more complications than VV ECMO, so if you can do VV, that's better. Your anticoagulation, ventilation, fluid management, dialysis make a difference. And of course, your underlying disease will also determine your outcome. Take-home message, timely ECMO for refractory hypoxemia. Outcomes are poor if instituted after your ventilator-associated lung injury, MODS. So don't dilly-dally. If you think of ECMO, maybe you should be doing ECMO, offering ECMO to the patient. VV ECMO is preferred for ARDS hypoxemia, even with shock. Only kids below 15 kilos, just for flows, you will have to put a VA cannulation. Thank you. Happy to take any questions.